Okay, thank you, the organizer of this symposium, for inviting me to discuss about how to optimize the treatment in myelofibrosis, especially in anemic myelofibrosis. We know that the clinical phenotypes of myelofibrosis is extremely heterogeneous. However, we can distinguish two different clinical phenotypes, proliferative phenotypes that are mainly characterized by leukocytosis, sometimes thrombocytosis, but without or very mild anemia. And the other is a cytopenic phenotypes that included patients with at least one cytopenia, mainly are presented by the moderate or the severe anemia and or thrombocytopenia, while is less usual to see isolated neutropenia. The cytopenic myelofibrosis is increasingly considered as a phenotype characterized by the specific issues that include, for example, more likely high-risk primary myelofibrosis that are more characterized by a higher grade of fibrosis or blast cells. These patients are often with a lower allele burden of driver mutation and are enriched in patients harboring high molecular risk mutated genes. In particular, U2AF1 seems to be strictly related with the cytopenic phenotypes. In addition, cytopenic myelofibrosis are associated with a worse prognosis, with a short overall survival, an increased risk to progress to blast phase, and the management of this patient is complicated by limitation of treatment option. In fact, if we consider the approved JAK inhibitor, we know that ruxolitinib and fedratinib are contraindicated in those patients with a platelet count below 15,000, and for ruxolitinib, that should be adjusted according to platelet count and need to be and the dosage need to be decreased in those patients with a platelet count below 100,000. Conversely, momelotinib, pacritinib have no contraindication according to the platelet count, even if in the datasheet of momelotinib is reported that the treatment should be interrupted in case of platelet drop down below to 20,000 and can be restarted only after recover platelet over 50,000 at 50 milligram below to the last given dose. Both NCCN and the British Society of Haematology suggest a specific algorithm for the management of myelofibrosis-associated anemia based on an adequate and inadequate serum erythropoietin level. And in both cases, they suggest the use of momelotinib in anemic patients with symptomatic splenomegaly or with an uncontrolled constitutional symptoms, regardless even the erythropoietin level. So I present this first clinical case that include a 64-year-old man with a high-risk primary myelofibrosis who are mutated in JAK2 and A6L1. The patient reported regular night sweats, bone pain, and symptoms associated with a splenomegaly that measure 8 centimeters below left costal margin. Blood test showed a mild leukocytosis, a moderate anemia, and in this patient was started treatment with ruxolitinib at 15 milligram twice a day. However, after 1 month of treatment, hemoglobin level dropped down to 8, and the clinician decided to reduce the dose of ruxolitinib to 10 milligram by a day. That induced a stabilization of hemoglobin, but the patient reported the maintenance of symptoms and splenomegaly. So patient at this time refused the proposed transplant, and the last CBC reported the anemia around 8 and platelet count around 100,000. So what would be your treatment in this specific patient? You switch to fedratinib, switch to momelotinib, switch to pacritinib, or you continue ruxolitinib at lower dose, or if you have other option, please vote. Okay, the majority of you decided to switch to momelotinib. I agree that continuing ruxolitinib may not be the most suitable option, considering the results of real-world studies in which it has been demonstrated that cytopenic patients have a lower rate of clinical response in terms of spleen and symptoms reduction, and this compared to proliferative group, and this results in a significant reduction in overall survival, with a median survival of 4 years in cytopenic patients compared to the double in proliferative patients. In a separate analysis of a real-world study, cytopenia has been reported as the most important reason of ruxolitinib discontinuation for about 40% of cases, in the majority of cases for anemia. In this retrospective analysis, including patients enrolled in Simplify-1 trial who are initially randomized to ruxolitinib and then crossed over to momelotinib, has been demonstrated that almost 60% of these patients required dose modification during the first 6 months. And regardless of the dose of ruxolitinib at the time of the crossover, the majority of patients switched to momelotinib without ruxolitinib tapering or washout, and started momelotinib at the optimal dose of 200 milligrams once a day. And in the first 3 months of treatment, the majority of patients switching to momelotinib maintain this dose. As expected, a patient initially randomized to ruxolitinib reduced significantly hemoglobin level during the first 3 months. However, in those patients who transited to momelotinib, we observe a significantly rapid recovery of hemoglobin level, approximately 1 gram in the first month, maintaining the response in terms of spleen volume reduction. And in addition, the transfusion independence rates in patients who are randomized to ruxolitinib and are initially not transfusion dependent, we observe a progressively increase of transfusion independence, rise to more than 45% after 3 months. The crossover to momelotinib. So this is the second clinical case that involves a 63-year-old man with intermediate 2 according DIPS or high risk according MIPS 70 plus primary myelofibrosis that are mutated in JAK2, A6L1 and SRSF2. He reported symptoms related to anemia such as fatigue, inactivity, but also a worsening of weight loss and bone pain in the last 6 months. At the physical examination, splenomegaly is palpable 6 centimeters below to the margin costal, and the blood test showed a leukocytosis with a moderate hemoglobin and a severe thrombocytopenia. Also in this case, a patient refused transplant. So what's your decision? Which treatment would you select for a patient with a moderate anemia and severe thrombocytopenia with leukocytosis? Fedratinib, momelotinib, pacritinib, or ruxolitinib, or other choice? Please vote. Okay. Half of you decided to choose pacritinib, and we know that in severe thrombocytopenia, ruxolitinib and fedratinib cannot be used. As regard pacritinib, in the pooled analysis of the PERSIS trials, demonstrate an effect of pacritinib in terms of SVR34 and the reduction of symptoms that was was achieving about 20% of patients compared to control groups. And similar result was observed in patients treated with momelotinib enrolled in Momentum in the subgroup of patients with platelet count below 50,000, and despite a similar rate of transfusion independence when compared to patients randomized to danazol, you can observe a significant response in terms of reduction of symptoms, but in particular in reduction of spleen, that's observed in 20% of patients compared known in danazol group. This is the third case. Is a woman of 68 years old with a high-risk primary myelofibrosis. She do not refer significant constitutional symptom, even if at the physical examination showed a huge splenomegaly with 14 centimeters from margin costal, and she was mutated in maple gene, AZA2, and KRAS, and CBC showed substantially a mild anemia and a moderate thrombocytopenia. Also in this case, a patient refused transplant. So what's your choice in a patient with a huge splenomegaly, with a mild anemia and moderate thrombocytopenia? You decide to start fedratinib, momelotinib, pacritinib, ruxolitinib, or other choice. Please vote. Okay. The majority of us decide to start ruxolitinib and as second choice momelotinib. I present you the result from the Simplify 1 that enrolled naive patient randomized to momelotinib and ruxolitinib, and as in particular in those patients with a mild anemia or moderate anemia, you can see that the clinical response in terms of CVR35 and symptoms are substantially similar. Conversely, the transfusion independence rate is significant in favor or patient randomized to momelotinib. Similarly, for patient with a mild thrombocytopenia with platelet count between 50 and 100,000, you can observe that only patient randomized to momelotinib have a spleen response in 40% of patients, and also in this case, the transfusion independent rate is in favor for momelotinib treated patients. So, summarizing, the selection of JAK inhibitors in patients with myelofibrosis should be driven by the presence and the severity of cytopenia. For those patients who present splenomegaly and constitutional symptoms with high cytopenia, ruxolitinib or fedratinib can be used as a first line, and considering to switch to momelotinib or pacritinib in case of the newal onset or the worsening of anemia and thrombocytopenia. Conversely, in cytopenic myelofibrosis, is recommended to use the momelotinib or pacritinib at first line, and the choice among these two JAK inhibitors should be evaluated according to the type of cytopenia, preferring momelotinib in case of anemia. So in conclusion, patients who are treated with ruxolitinib often develop an or worsening anemia, and this required a reduction of dose that is associated often with a worse prognosis. And switching to momelotinib in this patient may improve hemoglobin level, maintaining the spleen response. Pacritinib has been demonstrated effective and safe in patients with severe thrombocytopenia, similarly to momelotinib, considering that for those patients with a platelet count below 20,000, the treatment needs to be interrupted. And finally, momelotinib is considered as a suitable first-line treatment for patients with anemia, extending the benefit of JAK inhibitors in terms of reduction of symptoms and spleen, also in cytopenic myelofibrosis patients. And thank you for your attention.